In the early 90s, most of care was delivered on an inpatient basis, or certainly in affiliation with an urban medical center. Today, you can receive the highest quality, most complicated and sophisticated cancer care in virtually every nook and cranny of the United States. We hear a lot of talk about increasing the value of cancer care. I've come to believe that the data suggests that there's already tremendous value in the community oncology delivery system. And while we should absolutely strive to achieve higher levels of value, we need to be sure that we don't destroy the value presently in the system as we reach out for even higher levels of value. Recently, Dr. Pat Cobb presented some data at the Community Oncology Alliance Steering Committee for Medical Homes. He talked about what it took for his practice to support a patient for a 3-hour IV hydration visit. And it turns out that the cost of that would be about $120 for one of his private payers. If he had very reasonably referred that patient to the emergency room, the minimal cost of that emergency room visit would have been $1,000. Having presented to the emergency room, the patient would very likely have been admitted. In working with his local hospital administration, he estimated that the likely cost of a 24-hour stay in the hospital for that common problem would be $17,000. So comparing what he does for $120 versus what would be done by a hospital system for $17,000 is the quintessential example of the value community oncology is bringing to the pharmaceutical industry, to payers, to patients, to society at large, thousands of times every day. There's also tremendous value in community oncology in that community oncologists are utilizing generic drugs. Until recently, there weren't a lot of generics available in oncology. But over the last couple of years, we've seen a substantial number of generics enter the market. And to some folks' surprise, community oncologists have actually taken up the mantle, and they're using them with great frequency. So much so that we have begun to have to advise payers to look closely at their data before they make adjustments in their payment systems that might end up costing them more money than they might have expected. Prior to 1990, there were approximately 40 products that had a specific label or FDA-approved indication for oncology. What you see in the 90s is nothing short of an evolutionary burst of development, where from 1990 to the present, we've had nearly 140 new drugs and/or indications specifically for cancer. What that means is that we've experienced a fundamental change in the available treatments during this time frame, but also that as the portfolio matures, we're going to now see a tremendous number of products going generic. By 2018, the largest drugs in oncology, that being the largest spend, will have turned generic or have a biosimilar equivalent. By 2020, virtually the entire current portfolio will have turned generic or have a biosimilar equivalent. In the 90s, a pharmaceutical company could demonstrate their incremental innovation, bring that product to market virtually without competition, and name their price. Going forward, this won't be the case. They will have to bring a new product to market, demonstrate compelling advantages over generic Erbitux, generic Avastin, generics Vectibix, generic Neulasta. And so over the next 10 years, we're going to see even greater levels of value in oncology because there will be a baseline set of products that are already generic or have a biosimilar equivalent. We also now have studies documenting that the cost of care in an outpatient community setting is less expensive, more cost effective than the same care delivered in a hospital-affiliated outpatient center. But the difference between the cost for those two trajectories of care is surprising. Not only do the community oncologists improve in their delivery of care in terms of the formal treatment, drug selections, regimen selections, and control, but they improve in a more dramatic fashion in their use of unnecessary costs like emergency room visits and hospitalizations. Recently, an amazing study was published in the Journal of Value in Health. This study looked at the cost of cancer care in the U.S. compared to the cost of cancer delivery in Europe. The U.S. has had greater improvement in the survival rates for cancer patients than has Europe. Even after they controlled for things like earlier diagnosis, better screening, that might affect something like survival rate, after they used more conservative methods, including mortality rates as an indicator, they found that the money that we spent on cancer care as compared to that of Europe was vastly productive and of high value. In fact, they estimated by putting a dollar amount on the value of a life year gained that some $600 billion of value was produced over and above that which was produced in Europe for the same comparative treatment in the U.S. Even more shocking, they showed that during the period in which oncology leapt forward in the U.S., 1993 to 1999, that for every $20,000 of increase in cost of cancer care, we improved survival by 2.3 years. That's an amazing finding, and it's an amazing testament to the value of cancer care in the United States.